Good morning, everyone. Good morning once again, the viewers. On this cold morning, I am going to take again the continuation of the class, that is physiological changes and the maternal changes which is occurring during the time of pregnancy. Next we'll start with the next change is the hematological changes. The hematological changes, the blood volume which is going to be seen over here is going to be increased steadily, and the total blood volume increased steadily from early pregnancy to reach the maximum 35 to 45% above the non-pregnant level, that is at the level of 32 weeks. Then we'll talk about the plasma volume. Increase from 2600 ml by 45 to 50 percentage, that is 1250 ml in the first pregnancy and 1500 ml in the subsequent pregnancy, that is multiple pregnancies or multipara women's. Then we'll talk about the red blood cell mass. Increase in the blood volume, that is 1400 ml, that is in non-pregnant state, by 33%, that is nearly plus minus 450 ml, is due to the increased production of resulting of erythropoietin or action of SCG or human placental lactogen. The increase is steadily till the full term. The increase in the plasma volume is more than the increase in the red blood cell mass, resulting in the hemoglobins, that is physiologic anemia. However, the minimal HB accepted is 10 to 11 gram percentage. Values of the increased blood volume that meet increased demands for uterus as well as the baby, etc. This will protect against the supine hypotensive syndromes. This increase in the blood volume is helpful from the preventing from supine hypotensive syndrome. The supine hypotensive syndromes will be detailed. I'll explain in the later slides. Protect against the fluid loss in the labors. So whatever the excessive PPH is there, the postpartum hemorrhage, that fluid loss is also going to be rectified by the excessive blood volume, increased blood volume. Increased blood volume more than increase in the red blood cell mass is going to lead to decreased blood viscosity, which leads to the decreased peripheral resistance. Then blood indices. Decrease HB percentage and RB percentage, that is erythrocytes, decreases from 4.5 per millimeter cube to 3.7 per million per millimeter cube due to the relative increase in the blood volume, plasma volume more than the red blood cell mass. Then hemoglobin concentration loss from 14 gram per deciliter to 12 gram per deciliter will be there. Then the mean corpuscular hemoglobin concentration, that is MCSC, is having no change, whereas the mean corpuscular volume will be going to be decrease or increase or no change depending upon the availability of the iron. Fragility of RBC is going to be increased, that will result into the destruction of RBC. Next is reticulocytes. There is a mild increase in the reticulocytes count will be there, along with the ESR, that is erythrocyte sedimentation rate, is going to be increased from 12 to 50 mm per hour, that is millimeter per hour. That means the woman is vulnerable for a number of multiple infection or opportunistic infections. Next is the fibrinogen level increases from 200 to 400 milligrams per deciliter to 400 to 600 milligram per deciliter. So amount has increased exactly double what is there in the non-pre-pregnant state. Next we'll see the platelets. The platelets will be increase in the platelet counts will be, there is a controversy which resulting into increase or decrease in the platelet count. Then we'll talk about the total plasma protein. There is a slightly decrease in the total plasma protein. Mainly the albumin is going to be decreased, resulting in the decrease in osmotic pressure. Then we'll talk about the WBC count, that is white blood cell, which is going to be increased from 7,000 per millimeter cubes to 10,500 per millimeter cube during pregnancy, and add up to 16,000 per millimeter cube during the time of labor. So during the time of labor there is a more chance of infection, so this will be helpful to prevent from infection. Increase WBC count and increase its enzymes also, and lymphocytes will be, there will be no change. Next we'll talk about the coagulation system. This was till now we had seen about hematological system as well as the changes which is occurring in the uterus. Next third changes is coagulation system. There will be in the coagulation system, and we'll talk about the first will be platelet count. There is a controversy representing there may be increase or decrease in the platelet count. Fibrinogen level double to 600 milligram percent. Factors 8 is going to be tripled factor 7th and factor 10th are going to be doubled. Factor 9th and factor 13 is going to be slightly decreased, and fibrinolytic activity is going to be decreased. Therefore, the pregnancy is hypercoagulative state. All these changes are reversed after the labor with the decreased RBC production, and the excess iron storage is going to be seen. So what is the meaning of hypercoagulative state? Means all the level which is helpful for the coagulations are going to be increased over here. So that's why it is going to be known as hypercoagulative state. So the pregnancy will result into the increase in all the fibrinolytic factors and all the fibrinogen factors or platelet factors, and that will be going to be seen over here. Next we'll talk about the cardiovascular system. Now I'll pause the video and I'll meet after 2 minutes. Now we'll see the cardiovascular system changes. Cardiovascular, its name itself is representing that the changes which is occurring in the cardia and the vessels. So first in the changes in the heart. So the position, well, first we'll talk about the position of the heart. As the diaphragm is elevated progressively during the pregnancy and the apex is going to be displaced upward and to the left side, so it lies in the fourth intercostal space outside the mid-clavicular line. That means the apex of the heart is going to be little bit shifted to the left, and it is going to be lies on the fourth intercostal space out to the mid-clavicular line. Next is the pulse rate. The resulting pulse rate increases from 8 beats per minute, that is 8th week of gestation, and is going to be enhanced 16 beats per minute at the age of full term. Some episodes of ectopic beats and water hammer pulse is going to be represented by the woman during the time of pregnancy. Next we'll talk about the heart sound. The first heart sound becomes louder before mid-pregnancy, and splitting of this sound may occur due to the earlier closure in the mitral wall than the tricuspid wall. The intensity of the second heart sound may going to be increased. Next, the third sound, which becomes louder before mid-pregnancy and persists as such till 1 week at the postpartum. The fourth sounds may be detectable by the phonocardiography. Next, we'll talk about the murmurs, that is cardiac murmurs. Systolic functional murmurs develops the most of the women, usually early systolic, but mild systolic murmurs may occur and heard over a left sternal edge, and they are thought to be due to the functional tricuspid regurgitation of the blood. Next we'll talk about the ECG changes. The main features of the ECG may be attributed to the changes in the position of the heart. The axis undergoes the left shift by the 15 to 28 degrees, and the QRX complex becomes the lower voltage and the T waves become the flattened over here. Next we'll talk about the hemodynamics changes. The hemodynamic changes, first we'll talk about the cardiac output. In the case of cardiac output, increase may be by the increase in the stroke volume rather than increase in the heart rate, reaching to the maximum of 40%. And the above non-pregnant level, that is at 20 weeks of gestation, to be maintained at till the term age. Next is the cardiac output is distributed. 400 ml will be the raise of the uterus, 300 ml is coming from go to the kidneys, 300 ml go to the skin, and 300 ml go to the gastrointestinal tract, breast as well as heart. Next is the values. There will be the values is going to be distributed excessive oxygen to all the areas, and during the labor the cardiac output is increased more, particularly during the second stage, due to the pain in the uterine contractions and expulsive efforts pushing the blood into the general circulation. Postpartum, increased cardiac output is maintained for up to the 4 days and then decline rapidly. Then arterial blood pressures. Although the cardiac output increases, yet arterial blood gas is going to be decreased in the mid-trimester to increase again in the third trimester of the pregnancy. This is due to the decreased peripheral resistance, mainly affects to diastolic blood pressures due to the increased vasodilation, which is again supported by the increased metabolism, and arterioventricular shunts will be going to be seen. Next we'll talk about the supine hypotensive. Maybe develops when some of the women's late pregnancy while lying in the supine due to the compression of inferior vena cava by large pregnant uterus, resulting in decreased venous return and decreased cardiac output and low blood pressures, and to the extent of that maybe a fainting may occur. So supine hypotensive is mainly described in terms of when there is a late pregnancy is there, that means the mother is heading towards a second and third trimester of pregnancy. When she is going to be lie down on the bed, she is going to compress the she going to compress the inferior vena cava by the gravid uterus, and this gravid uterus will be going to be compression will result into decreased venous return to the heart and decreased cardiac output and resulting in the low blood pressure. Sometimes if the low BP is going to be continue for a long extent, it may result into the fainting episode in the woman. Next, decreased sensitivity of blood vessels. So this decreased sensitivity of blood vessels is maintained by the angiotensin II, which is otherwise well known as vasoconstrictor agents, and this will result into decreased venous return. So supine hypotensive syndrome, so you can see from the picture itself, this will be resulting into decreased venous return to the heart and decreased cardiac output, resulting into supine hypotension. The posture of the pregnant woman affects after the arterial blood pressure is going to, typically the pressure is going to be highest when she is in, blood pressure is highest when she is in a sitting state, lowest when she is in a lying state, and lateral recommended position, and intermediate when she is in a supine hypotensive or supine state will be there. Next we'll talk about the peripheral vasodilation. The peripheral vasodilation meaning is that when we talk about the dilation, vessels will be dilated in the peripheries of the extremities. So increased blood flow to the skin will be resulting this peripheral vasodilation, particularly at the hands and the feet, generally giving the pregnant women to feeling of warmth. Because of increased blood supply, there will be more vasocongestion will be there, that may result into the feeling of warmth as the blood is circulated from the blood vessels. So that will result into the warmth blood feeling. Next is in peripheral vasodilation, increase in the congestion of the nasal mucosa, leading to the common complaints that is resulting in terms of nasal obstruction, and that nasal obstruction will be going to be progress for a long time, may result into the bleed from the nasal cavity, and that is going to be known as or nares, that may result in the bleed and going to be well known as epistaxis. So increased bleeding may come in the later trimesters of the pregnancy. Then we'll talk about the venous pressure. So increased venous pressure in the lower limbs is due to back pressures from the compressed inferior vena cava by the pregnant state, mechanical pressures on the uterus, on the pelvic veins, increased venous return from the internal iliac veins, and increased pressures in the external iliac vein will be there. Next we'll talk about increased venous pressures in the lower limbs. It may predisposes, this increased venous pressure is predisposes by the means of edema which is going to be continued by the increased venous pressures or increased blood supply and varicose vein and the piles. So edema and the varicose veins in the lower limbs and the vulva is due to, why it is going to be seen, because of increased venous pressures, then relaxation of smooth muscles in the walls of the veins of progesterones, decreased osmotic pressures in the blood, increased permeabilities due to the progesterone and aldosterones, and increased intestinal pressures, and this interstitial pressure is going to be made by increased sodium retention. Next we'll talk about the varicose vein treatment. When the mother is having this varicose vein in the second and third trimester of pregnancy, what relief measures she has to adopt? So she has to go for avoid long period of standing. She won't stand for a long duration, and encourage active exercises. Avoid constricting clothes and keep the legs elevated while sitting and during the time of sleeps. Use of elastic stockings, they should be removed at night and applied with the leg elevated before getting out of the bed in the morning. That is, empty veins has to be made. Stretch panties may be necessary for vulval varicosities and all. Next we'll talk about the respiratory system. Till now we had completed the hematological and cardiovascular system. Now we'll talk about respiratory system. So anatomically, their enlarged uterus displaces the diaphragm up to the plus or minus 4 cm. So this enlarged diaphragm, diaphragms will be going to displace by the uterus by up to 4 cm. And this results of pushing of diaphragm, that may result into the diaphragmatic mobility is reduced and the respiration becomes more mainly thoracic region. Widen the subcostal angles and increase in the transverse diameter of the chest. In simple words, we can explain that the diaphragm will be little bit pushed upward, and because of pushing upward of 4 cm, the thoracic cavity is going to be enhanced in a perpendicular manner, and which will result into the decrease in the respiration, and the respiration becomes mean thoracic region, and with widen the subcostal angle. This may increase the transverse diameter of the chest. So transverse diameter of the chest is going to be enhanced by the diaphragm. Next is the respiratory functions. When we'll talk about the respiratory function, the respiratory rates does not increases during the time of pregnancy, but its normal rate will be going to be retained, that is 14 to 15 beats per minute is going to be seen. Overbreathing, that's the deep respirations occurs due to the excess of the or effects of the excessive progesterone will be going to see. This deep respiration by the means of excessive progesterone production, that is by the means of pregnancy hormone. Next is shortness of breath. The need to the breathe becomes conscious one, and the dyspneas are common complaints of the pregnant women, which may be due to the unfamiliarity and with the low carbon dioxide tensions and with alveolar capillaries. The vital capacity, the increased capacity, that is the tidal volume. This vital capacity is nothing, that's a generation of this by the means of inspiratory capacity, that is representing the combination of tidal volume and inspiratory volume. It's going to be decreased in the late pregnancy. The expiratory reserve volume, that is this volume is known as the maximum amount of air which can be expired after the normal expiration is reduced over here. The expiratory reserve volume is going to be reduced, and the residual volume is again going to be reduced over here. The reduction in that, the inspiratory capacity and the expiratory reserve volume or the residual volume is non-significant over here. It doesn't affect towards the pregnancy. Then we'll talk about the tidal volume. About the gap is inspired or expired in each respirations, the rises throughout the pregnancy and by about 40%. The tidal volume is going to be enhanced throughout the pregnancy by the 40%, which is the amount of gas inspired and expired. Inspired meaning is that when we'll be inhale the gas, and expired means when we'll exhale the gas, exhale the carbon dioxide over here. In each respiration process, that is going to be known as tidal volume, which is going to be increased by 40%. Now I'll pause for 1 second, then we'll have for future, and after 1 second I'll have once again the class and all. Now again we'll be in continuation of previous class. That's we are talking about the tidal volume. As I told you, this tidal volume is enhanced by 40%. What is the meaning of tidal volume? This means the amount of gas inspired and amount of gas expired in each respiration, in each breathing and all. That is going to be known as tidal volume. The hyperventilation is due to the increased tidal volume is not respiratory rate. Then we'll talk about the urinary system. Urinary system itself representing that, we'll talk about the kidneys and its related structures. So renal blood flow and the glomerular filtration rate is going to be enhanced. That GFR is going to be enhanced by the 50%, and this leads to increased excretions. So therefore there is a decrease in the serum creatinine level, that is due to the increased creatinine clearance, and the same for the uric acid is going to be seen. So why the decrease in the serum creatinine level? Because of that, due to the decreased or due to the increased creatinine clearance. Creatinine clearance is not going to be clear over here, and that may result in decreased serum creatinine level, and the same for the urea. So decreased blood urea level will be seen over here during the time of pregnancy. Increased kidney excretion by the glucose due to the increased filter load or filtration load, and this result into the decreased renal threshold and may results into renal glycosuria, that is the sugar is going to be seen in the urine. Therefore it is interpreting the result in the kidneys function test. You should take care considerations that the highest normal value of the pregnancy is equal to the lowest normal value of the non-pregnant state. So this will be the main significance over here. Next we'll talk about the ureters. Dilation of the ureters and the renal pelvis is due to the relaxation of the ureters by the effect of progesterone, will be seen over here. The pressures against the pelvic brim by the uterus, particularly on the right side, is due to the dextroposed uterus, and the dilations of the right ovarian vessels is going to be seen. Next is the bladder and the urethra. When we'll talk about the bladder and urethra, there is a frequency of micturition reflex is going to be seen in early because of the pressure on the bladder and enlarged uterus, and the congestions of the bladder mucosa will be going to be seen. Because of this, there will be increased urination or micturition reflex is going to be seen in early pregnancy. Next is the urinary stress incontinence. Is a term which may be develops due to the first time during the time of pregnancy, due to the decreased intraurethral pressures and decreased length of urethra, and spontaneously relieved on the later periods. Next, we'll talk about the gastrointestinal tract and the liver. So first, when we'll talk about the gastrointestinal tract, so what are the what are the changes is going to be seen? First, we'll see about the gingivitis. Gingivitis, there will be this represents that inflammation of gums. So there is increased vascularities and tendency for bleedings, as well as hypertrophy of interdental papillae is going to be seen. And the gums becomes more hyperemic and soft and may bleeds. Hyperemic means there will be increased blood supply, and whenever the little injury to that particular site or little pressures over that particular sites may result into the bleed, and the bleed will be by the means of traumatized or with the help of the toothbrush itself. Epules of the pregnancies is going to be developed, and that's going to be treated by the means of regular maintenance of dental hygienes or by the means of cryosurgery. In severe cases, we have to be burn that particular area. Next, we'll talk about the tylism. It is excessive salivations which is more common and association with oral sepsis, and it is due to the loss of swallow, saliva, and non due to the increase in amount. So why this tylism is going to be seen? Because of oral sepsis. It's not due to the loss of the saliva. It is due to the increased amount of the saliva. Because of increased amount of the saliva, there is excessive salivation is going to be seen. Smoking is going to be stopped, because and anticholinergic drugs may helpful, because this may helpful to reduce the excessive or reduce the excessive amount of production of saliva. Next, we'll talk about the nausea and vomiting. This nausea and vomiting in the ancient time and from till now, the woman who is having a morning sickness, this is well known as morning sickness, and usually in Indian scenario, when we'll talk about Indian scenario, the woman who's having a morning sickness will be going to be one or other way going to be known as pregnancy. One presumptive signs of the pregnancy. So this nausea is going to be accommodated in the morning time, and vomiting, that's if it is going to become in an excessive manner, that is known as emesis gravidarum, and it's going to be occur in early months of it. So nausea and vomiting, well known as a morning sickness, is going to be seen all the pregnant women who is getting pregnant in the first or second time in the pregnancies and all. In all the pregnancy, it is one of the major sign. That's the presumptive sign is going to be seen in this. Next is appetite changes. This appetite changes will be longing and craving will be going to be seen. The pregnant woman is going to be dislike some foods and orders, while some desire for some foods will be going to be desire. Reduced sensitivity of the taste buds during pregnancy creates a desire for marked sweet, sour and the salt foods. Pica. Deviations may be so extreme to that extent, eating the blackboard chalks and coal and the mud. So pica is usually going to be seen, is going to be accommodated during the time of pregnancy, and may going to be one of the crucial signs during the time of pregnancy. Next, we'll talk about the indigestion and the flatulence. That's the presence of gases and along with the indigestion. This is probably due to the increased gastric motility or increased gastric acidity, not motility, by the regurgitation of alkaline secretions from the intestine of the stomach. Sorry. Next, decreased gastric motility is going to be by the means of progesterone effects. So decreased gastric motility also will result into the stagnation of the food molecules in a particular region, resulting into the more acidic thing, and that may result in indigestion, and this may produce the harmful gases and going to be represents in the form of flatulence. Next is the heartburn. This is going to due to the reflex of acidic gastric contents of the esophagus. So the treatment includes, we will advocate the woman, she has to adopt small frequent meals to prevent the over distension of the stomach, and the evening meals should be taken 3 hours prior before going to the bed. Avoid fatty foods in terms of chocolates and smoking, as these relax the lower esophageal sphincters and again may go to the regurgitation of food molecules into the esophageal region and acid, and thus may result into increased acidity or a heartburn. And the bed should be raised at least 15 to 20 centimeter, and with the extra pillow is going to be used. Antacid preparations containing aluminum hydroxides is going to be favored over here. Then we'll talk about the constipation. When we are talking about the constipation, this will be decreased due to the Constipation is mainly due to the reduced gastric motility or reduced motility of the large intestine. This is because of the progesterone effect. So peristalsis is going to be little bit ceased, and the peristalsis movements is not coming in a healthy manner. Increased water reabsorption for a large intestine, that is aldosterone effect, is going to be seen. This particular constipation is going to be treated by evacuation of the bowel at the same time in each day by them promoting the bowel training habits. Diet rich in fibers in the form of vegetables, fruits and the bran. Milk, and avoid dehydrations by increasing the fluid intake. Minimize the coffee intake and the tea, as they are the diuretics and they may cause dehydration in the woman and resulting in again constipation. Increase physical activities and avoid sedentary lifestyle. The mother has to go for a little walk. Ambulation has to be required over here to relieve from the constipation. Sometimes we have to utilize the mild laxatives and may be needed, that is liquid paraffin is better avoid. It prevents the absorption of the fat soluble vitamins. In some women, iron supplementations may be caused. Gallstone, more tendency to the stone formation is due to the atony and delay emptying of the gallbladder. Next we'll talk about the hemorrhoids. Because of the continuous constipation, the mother may develop a condition known as medical terms hemorrhoids. So this is due to the increased mechanical pressures on the pelvic vein, laxity of the walls of the veins of the progesterones and constipation. Next we'll talk about the appendix. It is displaced. It's going to be displaced upward and laterally and may going to be comprises by the means of pain due to the appendicitis is higher in the non-pregnant state. Next we'll talk about the liver. Decrease albumin and increase globulin resulting in the decreased albumin globulin ratios and increase heat labile serum, that is by the means of the serum alkaline phosphate. So what is going to be seen the changes in the liver? The decreased albumin globulin ratios, increase heat labile, that's serum alkaline phosphate. The mother will feel more heats and all body. Therefore both the albumin globulin ratios and the heat labile alkaline phosphates are not reliable as liver function tests during the pregnancy. Next we'll talk about the metabolic changes. So in the case of metabolic changes, the first things what we have to be noticed about the weight gain. As we know that during the time of pregnancy, the mother will be going to be gain a weight, tremendous weight gain, and it is going to be seen in a normal pregnancy, the average weight gain will be comprises by the 10 to 12 kgs. So I'll take one pause over here and then we'll have again the class. Again we'll have a continuation of the previous class itself, metabolic changes, where we are talking about the weight gain. Usually the weight gain will be seen over here. The average weight gain during the time of pregnancy is 10 to 12 kg. Then it's going to be occur mainly in the second trimester as well in third trimester of the pregnancy. The rate of the weight gain will be 350 to 400 grams per week. Out of 11 kg weight gain, when we'll talk about 11 kg usually weight gain is going to be seen, 6 kg is composed of metabolic or 6 kg is coming from maternal tissues in terms of the breast tissues, in terms of fat gains, in terms of bloods and uterine tissues. And the 5 kg is coming from the fetal origin, that is the fetal tissues, placenta and the amniotic fluid. Next, out of the 11 kg weight gain, the 7 kg is water, 3 kg is fat and 1 kg is going to be known as protein. Next is the water reabsorption or water metabolism. Therefore, tendency of water retention is secondary to the sodium retention. There will be increased water retention in this woman during the time of pregnancy and water retentions may result into sodium retention also. Sorry. Next is the protein metabolism. There is a tendency in nitrogen retentions, that is a positive nitrogen balance for the fetal and the maternal tissues formation. Next we'll talk about metabolic changes, carbohydrate metabolism. Pregnancy is a potentially diabetogenic state which will be resulting in increase in the weight gain, and that may result into elementary glycosuria, may occurs in the early pregnancy. That's the presence of glucose in the urine. Renal glycosuria may occurs in the middle of the pregnancy. First will be an elementary and then the renal glycosuria is going to be seen. Next is the fat metabolism. There is an increase in the plasma lipids with the tendency of acidosis. That may come with the increased production of human placental lactogen. This human placental lactogen actions may result into increased fat metabolism. Next is a mineral metabolism. There is increased demands of minerals like iron, calcium, phosphate and the magnesiums. Next we'll talk about the musculoskeletal changes. There will increase mobility of the pelvic joints due to the softening of the joints and the ligaments caused by progesterone and the relaxation. So increased mobility of pelvic joints is going to be one of the major sign in going to be seen the musculoskeletal changes. It's due to the resulting in the softening of the joints and the ligaments caused by the effect of an hormone known as progesterone and the relaxin. Flattening of the feet is going to be seen. The feet will be flattened over here and because of the influence hormone. Progesterone, progressive lordosis, that is leading of lordotic joints and a backache by the increased high yield and pendulous abdomen in a multigravid resulting in the many complications. Next we'll talk about the backache. Usually the women who is getting pregnant, they may complaints of one of the crucial sign known as backache. Pardon me. The majority of the pregnant women complains of low backache which increases as the pregnancy advances. It is due to the increased lumbar lordosis. To counter the balance, the forward growth of the uterus is going to be seen. This puts in the strain on the ligaments and the muscles leading to the pain. Strain in the sacroiliac joints is relatively common. Progesterone causes softening and the relaxation of joints is going to be seen. Backache is if it is going to be get more complicated, so it is going to be treated by more period of rest. The mother, you advocate the woman who is pregnant over here, she has to take an ample of rest. Extra ample of rest has to be taken. Use of maternity corset and local heat in the form of hot water bag and infrared lamps. Analgesics given systemically or local creams. Paracetamol is a drug of a choice or non-steroidal anti-inflammatory drugs. The NSAID is drugs like indomethacin is to be given over here. Physiotherapies may be going to be needed. Orthopedic consultation is indicated if the pain is severe or radiated to the legs and in the pressures in the neurological sense. Next we'll talk about the leg cramps. They are common in the second half of the pregnancy, particularly at the night. The extent causes is unknown, leg cramps. It may be related to the shift of the blood away from the muscles, that is ischemic cramp, or it may be tetanic cramps or caused by the lack of calcium, increased phosphorus and both. So ischemic cramp as well as tetanic cramp is due to the lack of calcium in her diet or in her body. Next, what we have to be relieved from, what we have to advocate to relieve from these particular cramps. So this will be treated by giving additional amount of calcium tablets, reducing the intake of phosphorus containing substances like milk, meat and cheese. Vitamin B complex may be tried. Leg massage and hyperextension of the foot may be given during the attack. Next is a round ligament strain. Pain in the felt along with the round ligament and in the groin region is going to be seen. Pain will be unilateral or a left-sided, that is dextro rotation is going to be seen. It is due to the stretching of the nerve fibers and in the round ligament side. That may comes stretching of these nerve fibers in the round ligament side is going to be seen in the pain over here. So I'll pause for this and I'll meet after 2 minutes. Again, in the continuation of this class, when we are talking about the leg cramps, this is going to be relieved by excessive calcium intake in her diet and reducing the phosphorus in her intake, dietary intake, in terms of meat, milk and the cheese. Next we'll talk about endocrine system. When we'll talk about the endocrine system, first we'll talk about the anterior pituitary glands. So there is an increase in the size more than the increase in the vascularity. This will be renders anterior pituitary labile and for ischemia. So the increase in the size may go to result into decreased blood supply to the pituitary glands is going to be seen. Pregnancy cells is going to be modified appears due to the increased SCG. Prolactin level is going to be increased up to the 50 nanogram per ml at terms to ensure the lactation. Next we'll talk about the posterior pituitary gland. Does not get hypertrophy but increase in its oxytocin secretions near the age of term. Next we'll talk about the thyroid glands, and there is a diffuse slight enlargement of the thyroid glands during the time of pregnancy will be seen. Gland activity is going to be increased as evidenced by normal free T4 level, that is thyroxine, and due to the increased thyroid binding globulins. and increase. This may increase in the thyroxine level, may increase in the BMR, that is basal metabolic rate, by 20%, and triiodothyronine is also going to be increased over here. That may result in increased protein bound iodine, and this is increased triiodothyronine will be by the means of increased thyroid stimulating hormone. Next we'll talk about the parathyroid gland. Hypertrophy due to the increased demands of the calcium is going to be seen. Then suprarenal glands. Hypertrophy particularly to the cortex resulting into the increased glucocorticoid, corticosterones, and increased mineralocorticoid, aldosterone. Insulin increased mainly due to the human placental lactogens and because of anti-insulin hormones. Ovaries. Corpus luteum of the pregnancy functions till 8 to 12 weeks of gestation, where its function is taken by the placentas. Next we'll talk about the skin changes. When we talk about the skin changes, there is a persistence of the basal metabolic temperature, basal body temperature, that is BBT, is going to be elevated slightly over beyond the expected date of menstruation. Due to the increase, this is increase in BBT, that is basal body temperature is going to be increased because of increased production of progesterone. Spinal telangiectasis or palmar arrhythmia due to the increased estrogen or due to the cutaneous vasodilation is going to be seen. What is the meaning of cutaneous vasodilation? That is known as hyperemia. This may be lead due to the mass pallors due to the anemia with or without pallor arrhythmia. Increased granular activities, that is sweat or the sebaceous gland, and because of increased activities of the sweat glands, this may result into palmar arrhythmia or cutaneous vasodilation or hyperemia. Sensation of the heat and the nasal congestion. Next is the pigmentations. Pigmentation will be going to be seen on the cheeks due to the increased estrogen or due to the influence of an hormone known as melanocyte stimulating hormones or ACTH, adrenocorticotropic hormones. In the face, it will become in the form of chloasma gravidarum and a mask of the pregnancy. Butterfly pigmentations on the cheeks and the nose is going to be seen. It is usually disappear few months or after the labor. In abdomen, it is going to be represent linea nigra, that is the pigmentations in the midline below to the umbilicus. Midline below to the umbilicus. From the midline, it will go to the level to the umbilicus. So next is the stria gravidarum. So pigmentation in the lower abdomen, flanks region, inner thighs or a buttocks or a breast increase because this will be increased as the pregnancy advances. So silver, this brown appearance will be there, and it starts bluish. First it is going to be known as stria rubra, then it become pale to become white in color, that is the stria albicans after delivery, and which persist in the primigravida in the form of stria rubra. Only in the multigravida it is added with the form of stria albicans as well as stria rubra. Rubra, that will be a bluish in color, alba, which is in a silver in color. Both is going to be seen in the multigravida. It may be due to the mechanical stretchings or by the means of increased glucocorticoids, which results in the rupture of the elastic fibers in the dermis and exposure of vascular subcutaneous tissues is going to be seen. Next, we will talk about the secretions. Secretions of the some glands. So, increase of the sweat and sebaceous gland activity is going to be increased. Next is breast side. So, diagnosis in the primigravida and may persist after the pregnancy. In multigravida, it may be due to the previous pregnancies, and there may with the any hyperestrogen effect, so they are non-diagnostic for the pregnancy. In the first month, there will be increase in the size of the breast and the vascularity by the dilated veins, which is seen in the breast region. Mastodynia may be present with the range of tingling or to the frank pains due to the hormonal response of the mammary ducts and the alveolar system. The second month, that's the increased pigmentations of the nipple and the areola, and the prominence of Montgomery tubercles, non-pregnant nodules, non-pigmented nodules around the primary areola. That's going to become in a number of 12 to 20. Next is the Montgomery tubercles. They were thought to be enlarged sebaceous gland and are found to the left of the orifice of the peripheral active lacteal glands. So, in the non-pregnant state, there will be no presence of this particular Montgomery tubercles. But as the pregnancy advances, you can see from the dark nodules will be going to be seen in the primary areola, and which is having a number of 10 to 20. Next in trimester, when we'll talk about the third month, secretion of the colostrum, that is thick yellowish milk fluid which can be expressed from the nipple. Fourth month, a pigmented area appears around the primary areola, that is going to be known as secondary areola. Low limb signs. Low limb signs is going to be seen in the edema, bilateral and pitting and varicose vein is going to be seen. Next is talk about the neurological signs. Neurological signs, that is sensory changes from the compression of the nerves, tension, headache, carpal tunnel syndromes due to the increased edema, numbness and tinglings related to the postural changes. Headache. It is relatively common and attributed to the intracranial vasodilation. Is caused by the estrogen and progesterone. This is also by the influence of a hormone known as estrogen and progesterone, which may result in a headache episode. It may be troublesome in some of the second trimester but may persist throughout the pregnancy. However, the headache may be due to the lack of sleep, due to the overwork, or this will be going to be corrected by prescribing the analgesics. Next is the fainting episodes. It results from the lowering of blood pressures due to the vasodilations which occurs in the pregnancy. Insomnia. Insomnia during the pregnancy, some of the women are sleepy, some are getting depressed, and some may get irritable, and that may result into for insomnia. Next, we'll talk about the carpal tunnel syndrome. This carpal tunnel syndrome is caused by the compression of and medial nerves at the passes through the fibrous tunnel at the wrist, and as it results in the fluid retention and edema in the pregnancy. So, therefore, tingling and numbness and burning sensation affecting the radial sides of the hand. This is going to be treated by increased reassurance. We have to reassure the mother. Use of wrist splint has to be put over here. Dietary diuretics and non-steroidal non-steroidal anti-inflammatory drugs and local injections of hydrocortisones in the tunnel before the fibrous roof is going to be seen. That is known as retinaculum. Sometimes there will be required of operations, rarely needed due to the pregnancy by incision given to the retinaculums to relieve the compression. Other compressions like neuropathies affects the lateral cutaneous nerves of the thighs, obturator and peroneal nerves. Next is the leukorrhea. In the case of leukorrhea, the normal vaginal discharge is going to be increased during the pregnancy because of the excessive estrogen, and mothers may complain of this particular problem. However, it is become pathological discharges, increase monolial infections is going to be seen, which is a common cause of the pregnancy, must be excluded. So till now we had seen the pregnancy changes which is going to be occur in the pregnancy in the woman, and this will be the physiological and maternal changes which is going to be seen in the pregnancy. So I am here going to complete my class, where I think the viewers who you had listened about my class will have learned about some of the physiological as well as maternal changes which is occurring during the time of pregnancy. This particular video is going to be shoot on this particular topic because I had initiated my this YouTube classes. As my specialization is obs and gynae, so I am going to start with this particular topic. It's the easiest topic. If you have any query or any doubts, you can comment and you can follow this my channel. So thank you so much from my bottom of heart to my precious viewers, along with my colleagues, especially my spouse and my kids and my sisters who had supported me to develop this particular video. And thank you so much once again, and have a wonderful warm day. Go ahead. Thank you so much. Please subscribe my channel to learn some new things and some new concepts about the obs and gynae, and in futures I am going to update my videos in further. So with this will be fruitful for your academics also and for your competitive examination also. So thank you so much once again for my wonderful viewers for listening me and having this much of patience. Thanks a lot.